So welcome Arnaud to our PCM4U channel. Arnaud Bayle, I'm very pleased to have you. You're a medical oncologist by training and you do also research in health economics mostly.
Exactly.
So we're going to discuss about access to molecular testing in oncology.
Hi Loic, so many thanks for the invitation. Nowadays a lot of progress in oncology are linked to the ability to better understand the biology behind the cancer. So we have access to targeted treatment and to detect patient and molecular abnormalities. We need to test patients and to sequence their DNA or their RNA in order to identify molecular targets. So nowadays it's very linked to this progress and we want to discuss today, I think, the access to those testing, because it's important for a patient to have access to testing if we want to provide them with targeted drugs.
Yeah, clearly. So we've seen in drug development in oncology that almost, if I'm right, 70% of the new drugs, treatments are targeted toward a molecule or even a gene, a protein. So it's good to have the knowledge of the dysregulation of those molecules in the patients. How could you assess those? What are the techniques? Immunohistochemistry, next generation sequencing? Could you explain it a little bit to us?
Yeah, exactly. Behind the term of precision medicine, personalized medicine, we have many tests that we can use with patients, from very simple tests like single gene immunohistochemistry, like FISH. So it's tests that are not very costly, that are in the market for many years, but we have more and more new techniques like NGS techniques that allows us to test multiple genes at once. We have noticed a decrease in cost for those techniques during the last 10 years. And nowadays we are trying to have these techniques in routine for every patient. But we have, behind the term of NGS, we have a lot of realities, a lot of differences, and we have some very targeted panels with only a few genes. And we have also much more genes, like for whole exome sequencing, all the genome from the human genome. And we have also techniques like whole genome sequencing. So we have a scope and a range of techniques that is not nowadays available for every patient in routine. And I think the issue right now is to discuss how to give access to those techniques for patients, but also to discuss the clinical utility of those techniques. And we also need to find the more efficient way to finance, because for every health system it's a huge issue nowadays, because it's not so easy to find solutions for the financing of those techniques, but also, and we will discuss that I think later, it's not only linked to the cost, it's also linked to organizational aspects, and we are very facing huge difficulties in every healthcare system, and so we're trying to discuss that, I think, today.
Yeah, clearly. So you've made a survey across Europe to ask that to different medical oncologists or maybe health technology assessment system, maybe?
We have conducted a survey with ESMO, the European Society of Medical Oncology, because, as we said just before, we have many biomarkers nowadays for the targeted treatments. We have many techniques, but we don't know if it's available for patients. So we have decided to analyze the access of those techniques in a range of countries, in 48 countries in the European region. And we've tried to look at if it was available, for example, in routine for every patient, only in research, or not available at all, for example. We also looked at the barriers for access, for example, the cost, the access to treatment, and we looked also to the solutions. And for example, we saw in some countries that there are national initiatives, like in the UK for 100,000 genomes. In France, we have the Plan France Médecine Génomique, which are a huge initiative, but we also looked at other organizational aspects, like, for example, the implementation of molecular tumor boards, which are very important to discuss complex analysis. So yeah, we have tried to look at that, and if we want, we can discuss a bit the results.
Yeah. I would be very interested to have the result of this survey and huge work.
Yeah, it was a huge collaborative work, and we have a lot of partnerships with many national societies, for example. We had more than 200 experts from the field answering and giving us input on the access at the scale of their country. And what we've noticed is like for very simple techniques like immunohistochemistry, we put that in the group of single gene techniques. The access is quite good, which is nice because it's very important for example, in breast cancer, if you want to look at ERBB2 targeted treatment, or if you look at lung cancer, for example, for EGFR or ALK, and if you want to give targeted treatments against those anomalies. But on the other end, we looked also at more large panels like NGS, and unfortunately, it's still very complicated to access to those panels. And large panels are not very available in a lot of countries, and even in EU countries, even in high-income countries, there are a lot of disparities. So I think that one of the key messages is to say that nowadays precision medicine is not yet in routine for every patient, and you can have access, for example, in expert centers, but we don't have access in all the centers. So it's one of the main, I think, issue for oncology in the next coming years, to look at how to give access to those techniques. And I can also discuss, if you want, the reason and why it's not available. Of course, the cost of the test is one of the reasons, but it's not the only reason. And it's very linked also to the access to treatment. So access to treatment and access to testing are two very linked issues that we have to tackle together if we want to give access to patients for precision medicine. Yeah. And other facts that were interesting was about the organization and the process of prescribing. It's not so easy, and for physicians, for example, right now it's not so easy to prescribe those tests. And we've noticed that almost half of countries do not have access, for example, to molecular tumor board, and a minority of countries have national initiative that I was mentioning before. So we need more efforts for all the stakeholders and public, of course, stakeholders, if we want to make precision medicine a reality for every patient in their journey.
Yeah, see an heterogeneity. So maybe to have an illustration of what you're saying in practice, for example, for lung cancers, yes, you usually test a gene panel, 5-6 genes at once, for at least in some situation, because you have access to either EGFR inhibitors, BRAF inhibitors, even HER2 inhibitors. So it illustrates the link between the testing and the treatment which are available. So in which situation do NGS, so large panels, help the access of more targeted treatment for the patients?
I think lung cancer is a very good example, because lung cancer is like a model disease for precision medicine. We have many treatments to offer to patients, and in those situations it's pretty clear that it's better to have a panel, NGS panel, performed than every single test done, because, for example, you have the same quantity of tissue used for one single test than for the panel of 20-30 genes, and it's more efficient. So we have a lot of literature looking at the cost efficiency of testing thanks to NGS compared to single test in lung cancer. And I think there is no debate anymore. We need to have NGS, for example, in lung cancer. And we have recommendations from ESMO, which are going to be actualized. We will put the emphasis on this approach thanks to NGS. But even in other disease, even when you don't have a lot of treatment available with market authorization, I think it's still interesting to have the testing of patients because you can have access to clinical trials, you can have access to early access program. We have a lot of basket trials nowadays. So I think even if you are in a rare disease, we still are facing unmet medical need, and we know that testing patient can give a patient the opportunity to get another treatment, and I think it's very important to have that. But of course, there is also a question of finance, and we need also to look at the cost of this testing. And in my opinion, for example, nowadays, performing a whole genome sequencing for every patient is not feasible and not even, I think, the right way to proceed. We need more to discuss what is efficient. Maybe we can have a front testing with a small panel, and then if we don't find anything, and if the patient is fit, for example, we can look at more complex panels. So yes, maybe one of the key aspects is not only to finance, but also maybe to help the process of prescribing those tests. And for example, I think that in the future, we need more testing guidelines. We have treatment guidelines, but testing guidelines are still missing, and we need to be, as a physician, we need to know what test do I need to perform for which patient at which moment. And nowadays we have so many people doing different things that finally it's not very standardized. And I think another key point that we found in our study is the use of genomic scales. The more we will have biomarkers, the more we will need guidance. And we have scales that can help us because it's moving very fastly, and it's not so easy to know each alteration and each biomarker. And we looked at the use of, for example, SCAT scales, which was developed by ESMO, but also OncoKB. And we noticed that it's not so many people using those scales. And I think it's also one key message is we need more structure ranking, and the molecular tumor board can also help if we want to find the right decision thanks to the NGS panel that we can offer to the patient.
Yeah. We see that this is a multi-level decision, I would say, to pay for a molecular test for potentially many patients in routine. For example, colorectal cancer patients, if you want to go for NGS with multiple gene testing, it could be quite huge cost.
Yes, it's a very nice question. In health economics, we always speak about the cost utility, the efficiency, but we also look at the budget impact. And of course, the more patients you want to test, the more higher will be your budget impact. But I think one key point is also to look at the cost not only of the test, but also of the treatment. When you look at the cost of the test, maybe it's a few thousand euros, it will seem very high. But in fact, you look not only at the test, but you'll have to look also at the cost of the treatment behind the test. And I think that precision medicine is also a way to better select the patient. And when you will have a better selection, the patient will answer to the treatment with less, I hope, toxicity, and you will have treatment given to the right patient and not given to a lot of patients. So we need more biomarkers that help us to decide which patient could benefit from the treatment. For example, in immunotherapy, we speak a lot of targeted treatment in precision medicine, but immunotherapy, I think we will, and we begin to look at that, but in the next coming years, we will have biomarkers to decide if we have to test, if we have to treat patients with immunotherapy, and we will be better in the selection of patients. So, in fact, maybe the cost will be decreasing, even if the cost of the test is higher. The other thing is the cost of the test are decreasing every year, but for, of course, large tests like whole genome are still quite expensive. So yeah, maybe it's not the way we have to proceed. Maybe we have to focus on more selected panel genes. And finally, I think that if you look at the test, yes, we have to look at the way of financing the test. For example, in immunotherapy, we speak a lot of targeted treatment in precision medicine, but immunotherapy, I think we will be better in the selection of patients. Maybe it will be also a risk sharing between industrials and public stakeholders. Maybe we can have also some centralization. We know that in those tests you have a lot of economies of scales are linked to the size of your platform. So maybe performing a whole genome sequencing in every hospital is not very efficient. Maybe we have to have national platform. For example, in France, we have an initiative with 2 platforms, one for the north of the France and one for the south. And the 2 platforms, Sequoia and Oragen, are quite right now evaluating the efficiency of such an approach. But I think that for RNA-seq, whole exome, whole genome, the more you can have synergies and the more you can centralize the analysis, the better will be the health economics evidence that is efficient.
Yeah, very interesting and good illustration. I wanted to discuss a little bit about France Genomic 2025, which is an initiative that centralizes the molecular testing. So, is there a model that could be applied to many different countries, neighboring countries, or do every country have to find its own way to address this question?
It's a good question, but a difficult question. Of course, all health systems are different by nature. You have some centralized system, you have a regional system like in Spain or Italy, for example. And I think it's still interesting to learn from each other, and we can have the same issues and try to find solutions together. So I think we have to our more deep analysis of how to proceed. I do believe that the French example will be helpful for others, and we are discussing right now with, for example, Denmark, where we can exchange, and I think we need more exchange at the European level if we want to get knowledge from the other platform, for example. Maybe some analysis will not be done at the national level, but at the European level, and it's an option. Why not? We are doing, for example, evaluation at the European level. Why not performing also the test at the European level? It's a question that we can ask. And finally, I think one important thing is to look at the equity of access. The more we have initiative, but local initiative, the more we are creating lack of equity of access, and I think we have to focus on this topic, and we need to find solutions to be sure that every patient, even if it's not with a physician in an expert center, has the same chance to get the test. And it's not linked only for financing, it's also linked to, for example, the awareness of physicians. We need more awareness, and we need to train physicians, and it's moving a lot, very fast. We will not all be experts of biology and molecular testing, but we need at least to have a knowledge of what is mandatory, and I'm coming back to the guidelines of testing. We have to provide that guidance to physicians, and my thing also that patient has to be put in the center. I'm convinced that if the patient is aware that in his disease one biomarker is important, he will ask to have the test performed, and I do believe that he can play a role in getting the molecular portrait performed for his disease.
Okay, so I cannot thank you enough to make an advocate of this access and knowledge and sharing knowledge. Yes. With the patients, the physicians about molecular testing, and you're clearly in our aim in this PCM4U channel because we are doing education in a program that is personalized cancer medicine for all European citizens. So you summarize very well what we are doing, and I thanks a lot your presence and your vision on this very nice topic. Thanks a lot, Arnaud, and see you very soon.
Many thanks. See you soon.